So welcome back to the Waiting Room Revolution. Today we are very excited to have Dr. Connie Siskowski on the show. She is an RN, a PhD, and a caregiver advocate. She was the founder and president of the American Association of Caregiving Youth. She's calling from Florida today to join us, and she's been named a top 10 CNN hero before. So we're very excited to learn about how young carers intersects with the waiting room revolution. Hi, I'm Hsien Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Welcome, Connie.
Thank you so much. I'm really thrilled to have this opportunity to be on your show and talk with your listeners.
I thought I'd start with your own personal story of how you started this journey and ended up becoming the founder of a national organization focused on young carers.
So I never, ever expected to be on this journey, but it's like you walk along and you just go through that door that opens. So, I took care of my grandfather, who was really my hero, when I was in middle school between the ages of 11 and 13. We lived with my grandparents, and my grandfather was like my buddy. You know, he taught me how to fix a light, to do a lot of different things. And I think my grandmother probably didn't have a good caregiving gene, if you will. He kept working part-time until he was 84. And I always kind of joke to say that that's probably because he didn't want to be home with my grandmother all the time. But, and then, you know, his health really started to decline. He had heart issues. And so as his health declined, I moved in from my bedroom into the living room to be closer to him. And so then one night in March of 1960, I went to take him his medication at 2 o'clock in the morning, and I can still feel his skin that was so cold. So, you know, this was at a time when trauma in children wasn't recognized. Mm-hmm. And so not only did I have the trauma of providing personal care, my mom, by the way, worked 2 jobs. I had a brother who was not involved in the caregiving aspect at all. Mm-hmm. And as I said, my grandmother, this was really not her thing. She could cook good, though. And so in addition to, you know, the trauma of the care and his death, I didn't have him in my life anymore, right? So I missed having a dad, having a male figure. None of this was really realized until I was in counseling as an adult. And thankfully, my counselor was astute enough to point, you know, some of what I had gone through as a child out to me. And so that helped me heal. And so I did go into nursing, and I went into cardiac nursing. So, you know, it all kind of, you know, goes together. When I went back to school and got my master's, it was in public administration with a major in health administration. And then my work throughout the healthcare system was pretty varied. And I even I was recruited to open an extended care facility in Newark, New Jersey. And so I had that experience also.
So you were a young caregiver, and you started your career in critical care nursing. I also read on your bio that then you went on to work in a hospice in Florida, and then you went on to provide home care. I'm curious, though, how did your professional career pivot to begin focusing on young carers?
I was waiting to go into a meeting at the National Council on Aging in Washington. And while I was waiting, I looked down and I see this brochure, and it's called Faith in Action. And it was a program of the Robert Wood Johnson Foundation. And I thought, you know, people could really use this, which was focused on volunteers to help people in need. And so I came home and met with my minister who said, "Well, I think this is a really good idea, Connie, but I'm too busy." So he introduced me to some other people. And bottom line is, we began Boca Raton Interfaith in Action. And so we deviated a bit from the typical faith in action model, which is attached to a particular religion, because our population here in Boca Raton is pretty diverse. And we didn't want any barriers to access care. So that was in 1998. And that same year, I had the chance to go to the first international conference on caregiving in London.
Mm.
And it was there that I learned about young carers. I was kind of taken, and that summer I went on a mission trip with kids from my church. And one of the boys had lost his dad recently, and another girl's dad had pancreatic cancer. And kids were just worried about their parents, about their grandparents. So, all these little things just kind of piled up along the way. Little seeds were planted, and they were about to bloom.
And Connie, how did you then get into research?
A door was opened. I heard about a survey that was being conducted in Palm Beach County, Florida, of middle and high school students. And I was able to include a family health section at the very end. So it went to over 12,000 kids. And more than 1 in 4 of them who were caregiving said that they were either missing school, not doing their homework, having trouble focusing, or some combination of them both. So this survey, the purpose of it was to ask kids what helps them learn and what doesn't. And that's how the school district got involved. But, I don't know what exactly it's like in Canada, but at that time, which was in like 2002, people were starting to get worried about the high school dropout rate.
Mhm.
And they were looking at, what's wrong with the schools? What's wrong with the teachers? There was no understanding about what's going on at home with these kids.
Mm.
So it was like too early on, even though I had this nonprofit established, that people really wanted to invest or deal with the issue. It's like one of the county commissioners said to me one time, "Well, Connie, maybe people don't want to know, because it's like if people know, then you have to do something about it."
Mhm.
So, yeah, that was pretty revealing, and probably a little bit too true. So, I had come to know people on a national basis, and I shared the results of our work in Palm Beach County. And as a result, Carol Levine, who's an amazing person, who is at United Hospital Fund Foundation in New York, convened a meeting in 2003 and brought over some people from the UK, as well as some people that were looking at some of the issues surrounding HIV in New York. And so at that time, at that meeting, Rick Green, who was with the Administration on Aging, said that they would fund the first national study on caregiving use. And so that was released in September of 2005, and it showed that there were at least 1.3 million children ages 8 to 18 in that role. So with that came some media attention. So because, people, it's like, what the kids do is behind closed doors. People don't see it. They may see some kid pushing somebody in a wheelchair, but there's not the thought process. Well, what happens when they get home?
Mhm.
What else is this child doing?
Mhm.
So we were able then to start, people talking about this more. And in March of 2006, there was a study called The Silent Epidemic, and it had been funded by the Gates Foundation, released by, I think, Civic Ventures. And it looked at young adults who had dropped out of school, and 22% said it was to care for a family member.
Wow.
So between our study, the national statistics, the media attention, and that study, we were able to get funding and began the first caregiving youth project here in Palm Beach County in 2006.
We have a lot of listeners to the Waiting Room Revolution who are caregivers, and usually older adults, so probably less that are younger. So I have a two-part question. Like, what do you think is, from what you've seen and heard, is the same? What are the challenges that are the same for young carers and maybe the typical older caregiver? And then the second part of it will be what's different. But what have you seen that where they have challenges that are common?
Well, actually, what the kids do and what they feel very much mimics the adult. You know, if you look at the school as the workplace of the child, and you look at employed family caregivers who, you know, may miss work, who have what they call presenteeism. They're there, but their mind is elsewhere. Or you know, they're not working efficiently, they can't take a promotion, they may even quit work. And so the children go through those same things. And I know that when I was at that first conference and I presented some research that we had done with the National Family Caregivers Association, and people from other countries also presented, the effects are the same, you know, of caregiving. It's hard. It's stressful. It takes up your. It's hard enough for us to manage our own lives, right? Much less manage somebody else's. And
Yeah.
then the relationship changes, and that's a big factor because, you know, no longer, say for a spousal caregiver, do you have that equal partnership? Your role changes, and for the kids, the same thing. You know, especially today, we have more grandparents raising grandchildren, and they've done this for a variety of reasons. And so then all of a sudden, the grandparent becomes sick, and then the child becomes the caregiver. So, you know, and at the same time, you know, there's the kids don't have the memory bank. They don't have the experience bank that adults have. But you know, what we've really seen is that you try and educate the population about caregiving, but until you're really ready and motivated to learn, you don't have that understanding of what you need to do. And so it's really a unique person who would have that understanding unless they've been through that situation themselves before.
Yeah, I think I'm appreciating this whole layer of caregivers that I guess I didn't really appreciate until I was listening to you, Connie, and listening to the very, you know, striking and compelling data that you collected, which I'm sure isn't very different than what we would find here in Canada. And, you know, Hsien and I focus so much on the adult caregiver. And, you know, we appreciate that adult caregivers end up in their role just by happenstance. They don't get to interview for the role. They don't get a job description. They don't get vacation time. And the same is true for young carers as well, that they just happen to be in that situation, that they end up with that role. And because they're silent caregivers, they are probably less likely to advocate for themselves than the adult caregiver for information that would be grounding for them in their role. Like, for example, asking big questions to doctors or nurses, like, what can I expect with my grandpa or my grandma? Or, you know, how is this going to look over time? What's it going to require of me, and for how long? Because they not only might they not find their voice to ask or even know to ask those things? But they're probably not even present when their adult person they're caring for is with the doctor or the nurse. So they don't even get the opportunity to ask questions either. So they just go with the flow.
Many of the kids that we work with need to translate on behalf of their families.
Yeah.
And so, that adds a different layer. And so they often do go to the doctor, and sometimes by going to the doctor, they miss school. So, and the doctors sometimes talk to them, particularly if they're caring for a parent who doesn't speak English. So, and then, the information may be beyond what the child can digest, and there may not be words in their own language. Now, yes, happenstance sometimes, but in some cultures, the children are assigned, and otherwise they step up to the plate. But unfortunately, people don't do caregiver assessments, to see if that person who's going to be the caregiver is qualified. The AMA does have a caregiver assessment, but people don't know to use it. One of the things that we're trying to work with right now in nursing, in medicine, in education, in social work is to include a module on family caregiving of caregivers of all ages in curriculum, because teachers, educators, they don't know what to ask, and so until that happens, it's all just part of a process that has to be in place in order for change to occur.
That's such an important point, this idea of caregiving curricula being embedded in the formal training of healthcare providers. I hadn't thought of that angle, but how important that is to teach doctors and nurses and social workers how to interact, assess, support, work with the informal caregiver layer.
Yeah, because even we had a boy, he complained to the school nurse that his back was hurting, and he was one of our kids, and so one of the things we do is a home visit. So at the time of the home visit, we discovered that he was caring for his brother along with his single mom who worked, and they lived in a small house, but they had a high stoop. And mom worked as a maintenance person at a facility. And so they had a van. And so, but in order to get his brother into the van, he and his mom had to lift him in and out of the house, up and down the stairs. So it's no wonder that as his brother got older and heavier, that it was causing more of a strain. So thankfully, we were able to find somebody to build a ramp, because, when you have a high stoop, the ramp has to have a long slope. It can't just be, an acute angle. And so when that happened, then the mom could take her son in his wheelchair right into the house and didn't have to wait for our student to get home, which then freed him up to have some socialization away from the isolation that he otherwise felt.
Yeah, it requires such a holistic assessment around the young carer, in so many different ways, including home visits and the environmental scan, and, the different ways that you can offer support that would offload the young carer in creative ways.
Yeah, and by strengthening the family, it helps to reduce the stress on the child also.
Yeah.
Yeah, I was gonna say, like, because I've read about some of the programs that you run, and I'm curious from your perspective, what is the impact of these programs the on the learning, on the development of young people, and especially because I'm just trying to think of the parallel here for Waiting Room Revolution. You know, when people realize there's information that they were missing and they get it, and they move from being in the dark and in the know, and getting the right diagnosis, using recognizing that what they're doing is caregiving, for example, getting the label, there is a release of stress because they find their community, they feel seen, they feel validated. So I'm wondering, for young carers, is it similar when they are recognized and have a community of which allows them to have part of their life be just as kids or teenagers?
Yeah, so it's very revealing. So we do a screening process for kids in beginning in sixth grade, and we've developed a level of responsibility that's very much based on the adult level of burden or level of care. And so you have to be in the top three levels in order to be in our program and use our resources. So one of the first things after we get the screening done and we do the analysis, our family specialist, who is a master's prepared social work, meets with the student and lets them know about the program and then invites them in. And one of the first things that we offer is a 6-week skills building group. And it's between 6 and 10 kids at a time. We do it in school. And all of a sudden, the kid learns that they're not the only ones. And a special bond grows between these students. So that's really special. It's so important, no matter what you're going through, to know that you're not alone. And we do, this is like a foundation group where we do things like problem solving and communication and managing stress. And the kids each time, like do a check-in, what's going on. And then when we do an activity and we involve kids from multiple schools, their world grows bigger and they realize it's not just in their school, but it's in other schools too. So that alone is very powerful, in addition to giving them some tools that they can use to help their caregiving and particularly their stress. And also to encourage them that there's a life beyond, and the importance of having, their own life and self-care and planning for their own careers.
Yeah, I mean, there's so many things I want to say, but I'm appreciating that educating people or providing courses for young carers, you're saying is very time sensitive, that the person has to be in the role before they're receptive to receiving any kind of education. So it's not like you can just say, okay, all sixth graders are going to have education in being a caregiver, because if they're not caregiving, it just goes in one year and out the other. It doesn't have the same weight. So I'm just trying to, in my head, draw some parallels with when we might offer such a thing in the adult world, or just this idea of time sensitivity with education and support for people.
Yeah, I think that's critical. Right now, we're speaking with some people who had reached to us from the state of Rhode Island Department of Education and their school district, which has been having challenges with students and graduation rates. And they're trying to reimagine high school, because it's not only the student who's family caregiving for someone who's ill or disabled, but also it could be now students have to work, particularly with the pandemic, where people have lost jobs and the kids have had to go to work to help their families, or they may be needing to help a sibling. Of course, some of our caregiving youth also have to help a sibling. but that all that takes away, and we're trying to help them understand the difference between essentially babysitting
Mhm,
versus family caregiving,
mhm,
and
Mhm.
how different it can be.
mhm.
One of I don't know if you all require like community service hours for kids to graduate from high school,
Yes.
but we do, and so our kids fill out a log sheet, and we worked out with our school districts so that we can award prorated community service hours for what they're doing at home, to
Oh,
take that burden away, because they don't have time to go volunteer someplace else.
I'm aware that the trajectory of caregiving probably varies. And I'm wondering if your approach to supporting young carers differs. If they're, for example, caring for a loved one who has a progressive life limiting illness, who has a shortened life expectancy, and that role is going to be a temporary role, versus someone who's looking at being in this role for decades and decades, if it's to care for a sibling with a chronic condition, or a parent with or grandparent with a disability, but they're not going to die from it. Is the approach different depending on the caring trajectory?
Our approach per se is not different. What types of resources we offer um, will vary depending on that situation, but also helping the child, who may be experiencing the death of their loved one, helping them, when we know that it's a terminally ill single parent. One of the things that we've done is, knowing that that child will probably have to go in foster care if
Mhm.
there's no other family around, is trying to make that transition as easy as possible, so that we can identify a family that, may be the family that they'll be placed with,
Mhm.
so that that can help, as well as to provide grief support. Um, the kids stay in our program from sixth grade through high school graduation, so the average time that they spend with us is about 5.5 years,
Mhm.
because obviously life happens and not everybody enters in sixth grade.
You talked about supporting young carers over time, sometimes for many years. And I'm curious how your approach or the services that you've provided, have they changed due to COVID?
What's really interesting to me and really heartbreaking recently is that I think, I don't know how the media is with you all, but with the pandemic, there's been so much focus on death related to COVID, that it has the kids very anxious. And we usually have an overnight camp, and at some point in the camp, usually after breakfast, after they've had a night away, we pass out note cards, and they write down, what worries them. And so this time, because of COVID, we couldn't do overnight, so we kind of packed everything into a day. So after lunch, we did this exercise, and for the first time ever, 1/3 of the kids were worried about their care receiver dying.
Mm.
And this had never shown up before. And the only thing I can think of is the media, and how people have talked about death, and how afraid these kids are. And, they're kids. And so as a child, the world centers around you, and it's like, what's going to happen to me?
On one hand, it's possible that all the talk of death and dying during the pandemic has raised alarm bells for these young carers. A third of them, you said, responded that they felt anxiety around that. But is it also possible that it's almost like a good thing in a way? Not that they're scared about it, but that the discussion around death and dying has given them permission to admit that they were and have been worried about their um, loved one dying. Like, is it possible that the people that are scared of their loved one dying, that the loved ones are actually at risk of dying?
Well, I think that's a really good point, Sammy. And, maybe that's always underlying. But the reality is that the majority of people who these kids are caring for don't die, in the immediate future. Last year, I think out of 400 and something kids, we had maybe 5 deaths. So, because, the management of chronic illnesses has improved so much, and people are living longer with chronic illnesses and needing care.
I wonder though if it's an opportunity, because we know we're all living in a death-denying society. And I'm appreciating what you're saying, that most of these loved ones are not in fact dying. So why should we worry the kids about death? But in a way, can it be turned into sort of an open discussion about death and dying, and normalizing death and dying as part of the life cycle? But good news, young carers, your loved one isn't there yet, but let's talk about death and dying. Do you know what I mean? Like, almost like, I know that's not your main mission, but it's one of our missions, is really to help assuage this crisis we have of a death-denying healthcare system and death-denying society that leads people to close the doors around discussions around fears and anxieties about death and dying. And so any opportunity it goes back to this education at the right time. If COVID has raised fears for young carers about death and dying, wonder again if that's an opportunity to go there and at least with this group of people, create a population, a community of young carers who are more woke about death and dying, and at the same time make them feel more comfortable with the fact that their own loved one isn't imminently dying, but that it's okay to talk about death and dying.
I agree that it certainly is okay to talk about, and Sammy, I think you make a really good point, something that we should probably consider.
What have you learned from other countries? Because this issue is not, unique to Florida or anywhere. I mean, there's examples of great ideas, or this issue is global, and there have been, good ideas across, the globe. So have you had experiences from and able to learn from other countries that you think are good models for what we could do different?
Well, in the beginning, we used some of what I had learned from the UK model. But what was interesting too is that then, we thought, well, how do we get to the kids? And so that was through the schools. And so some folks from the UK came over to see our program, and then wound up having a go-to person in the schools in the UK. So I think that, working between systems of healthcare, education, and the community are really critical. And I think that we do a good job of that when I look at and I think we're further along in that some of the other countries are.
I can imagine that the first things first, I'm thinking, I wonder how we're doing here in Canada. And as you were talking, I was thinking, I guess the first step is to figure out how to identify young carers. So how would we go about if we thought, okay, Connie, we're going to do this better here in Canada? Okay, step 1, identify young carers. How do you do that?
Well, as I mentioned earlier, we do a screening in 6th grade.
So you screen So it's become standard screening in 6th grade in a small number of schools in Florida?
In Palm Beach County is a large county, and the school district here is the 10th largest in the country.
Mm.
And so we initially worked with their Department of Research and Accountability. And so the school, the middle school, sends out an opt-out form to the parents to let them know that this screening is going to go on. And then if the parents don't sign the opt-out consent, then we do the screening process.
Wow. So
I was going to
why-
ask, what are the questions in the
Yeah.
screener? Like, what are some of the things that you're asking for in the screener to know that
Well,
this is something we should...
it's a very short screen. It only has 6 questions, but it asks if there's somebody in their home with a special medical condition, and the focus is on medical. And then if there is and they help, is the person living with them or close by? And then it goes on to ask the types of activities that they do, separating out the ADLs and the IADLs. So they just have to check that off. And then it asks how much time that they spend. And the time is broken up on a weekday and a school day. And the purpose of that was to help them quantify it a little more, because adults are asked, how much time in a week, and we wanted to make it easier on the kids so that it takes only, less than 10 minutes for the children to complete that. And then we're able to do the analysis and then meet with the student. So that's how we identify about 70%. And then in the schools that our formal program are in, sometimes we get a referral from one of the school staff.
Mhm.
We also, may get a referral from another agency. And we do lunch and learn sessions like twice a month in the school. And we focus on a particular diagnosis, usually looking at the top 10 diagnoses of the care receiver as part of a learning tool. And then other kids come up and say, oh, I do this, and then we talk to them.
Yeah.
And then they get entered.
So people who might not have screened positively in the screening, or maybe this is a different grade in school, but so most of
Right.
both people are identified doing the screening form, but then there's another smaller number that come to you either by direct referrals from teachers or because they just bubble up because they've attended one of your sessions. Yeah. I feel that this is so important that it can't just be Florida. It's got to be.
Well, I agree. My ultimate goal is that none of the children in our country, in your country, should have to drop out of school because of family caregiving.
Do you know what?
And our high school graduation rate is like 98%. And a lot of these kids are from financially insecure homes and minorities. So that's about 20% higher for this same population, if they didn't have the support. So it's really, you can build a good economic model because it's a good investment, because we want healthy, productive adults. And I don't know about in Canada, but here we need more people in the healthcare workforce. And if these children are supported properly, a lot of them want to go into healthcare.
Well, just like you, Connie, you became a nurse, no doubt, because of your personal experiences.
Yeah.
But I'm feeling like very energized by this conversation and curious and alarmed at the same time, because I will admit, I really don't know what the data and statistics look like here in Canada, but I can't imagine that it would be much different. And I am unaware, I'm ignorant of what processes are in place to screen and identify young carers and any kind of structured support that's in place. You're inspiring me, Connie, with your work.
Well, that's a good thing. And just one other point is that throughout the United States, there's a thing, a survey called the Youth Risk Behavior Survey, and
Yeah.
it's through the CDC. And so after much discussion, we were able to get a caregiving question on the 2019 Spring Youth Risk Behavior Survey.
Mhm.
And so it showed that 23.6% of middle school children and 16.4% of high school children were doing some type of caregiving. And so when we looked at, and this is just in public schools,
Mhm.
and so when we looked at the numbers, it's more than 290,000 kids in Florida. And when you compare, so in Florida and in the States, children who are in foster care or who are homeless are recognized. But at that same time, there were 95,000 children of all ages who were homeless and 15,000 children of all ages who were in foster care. And, but people can get, they have a visual of what a child who's homeless looks like, or someone who's gone through the trauma and been in foster care. And so, if you say caregiving youth or young carers, people don't know what that is.
Mhm.
And so that's why education is so important.
There is a phenotypical look when someone is not well cared for themselves, right? But a young carer.
Well, and our kids can have that look too.
Well, they can, but they can also just look like anyone else. And that's the danger as well.
Exactly. And the other conundrum is that the person that they're caring for may look well. And so it's a lot easier for educators and others if, your mom is in a wheelchair or using a walker or a cane to say, oh, you have a problem. Whereas like one of our moms who had MS, with MS, you get more tired as the day goes on.
Mhm.
And so she was talking to somebody at the school and they were sure that she had an alcohol or drug problem. And, so we had to educate them that it's not that, it's her disease. In fact, one of our kids on their little worry cards had written, what do you do if your person looks normal but isn't? And that happens also with mental illness, with brittle diabetics, with people with heart disease.
Yeah.
You don't recognize them as somebody who requires care.
Mhm.
Yeah, that's what I was going to ask. What those you said, the sort of the top 10 conditions. I'm guessing they're not all just sort of cancer. They are varied, including mental health and addictions, potentially, and various things. But I think what are those conditions? It would be interesting for us, for our listeners to be aware.
Actually, the kids in our program pretty much follow the general statistics, but what we don't see are a lot of our children with substance misuse in the home, because we have to get parental consent for the child to be in our program.
I see.
And so that's not as likely to happen.
I see.
So what are the top 10, Connie? You don't have to know all of them, but what are the top 3 or
disease is definitely, up there with cancer, diabetes, kids on the autism spectrum, we're seeing more of that, as well as like functional decline for older people, strokes.
So when you say autism, it's like caring for a sibling with autism?
Right. Mm-hmm.
Yeah.
Or other congenital, illnesses.
Yeah. Gosh, I am a palliative care physician and I care for people in their homes. And I have to tell you, this has not been on my radar. I care for adults And I'm always on the lookout for the adult caregivers, of course, and I'm simultaneously screening for distress and burden and questions, and I care for them as a unit. I also am watching for little ones. So kids and, how they're experiencing the adult's illness. But I haven't really been looking for kids as young carers. So I am
Well,
woke.
what's so interesting is that I was over in Tampa one time and talking with this physician who deals with medically complex children. And he said to me, "Well, Connie, before I talk to you, my focus has always been on my patient, not on his brother who was suctioning him."
Oh, okay, that's not good for me.
So,
For
but it's the same as with you, Sammy.
yeah,
Your
yeah.
focus is on your patient and the surrounding
Patient,
family
yeah, the patient and the adult caregiver
caregiver.
usually,
Right.
or the kids that are, grieving, but not in the function as young carers. Although when you're talking, I am remembering a patient with ALS, a woman who had two young children um, in middle school. I can't give too many details, but one child had autism, and the other child, oh, and the husband worked after school and in the evenings. Okay, if you're following me. So one child was left at home after school until the father came home, caring for his mom with ALS, the sibling with autism. And I'm feeling extremely guilty right now. I remember thinking to myself, this is so complex in here, but I didn't call him out as a young carer.
Yeah, it was one of our families with ALS. There were a couple of siblings, and we helped them to organize their schedules so that they could each have time off to get their homework done.
Mm-hmm.
But
Yeah.
I'm woke, Connie. I just have to tell you that we hope that our audience learns a lot, but I've learned a lot, Connie.
One of the barriers that that we often hear, that clinicians feel like, I'm getting the adult patients again, don't want to know, and so they don't go there. But I'm wondering what your experience has been for younger caregivers or young caregivers. Do they find the same barriers where they're talked to differently, or they are not recognized as having vital information and therefore face barriers of trying to ask questions but sort of being ignored?
Well, sometimes they're ignored, or sometimes they're spoken to um, because there's a realization that that's how things are going to get done.
So it's a bit of both. It sounds like sometimes,
Yeah.
yeah, it depends on the
Hmm.
situation. Either they have to
Yeah.
step in and be the full, the main everything,
Translator. Yeah.
yeah, or the opposite. They're forgotten about and pushed to the side. I see. Interesting.
This population would benefit hugely, these young carers, from having skilled and dedicated occupational therapists involved, as well as child life therapists. When you think about it, we think about their roles in other populations, but really, I can imagine a whole discipline being focused on supporting young carers, a multidisciplinary approach. Connie, do you have any experience with occupational therapists or child life specialists when it comes to supporting young carers?
Not really. Just long ago when I was in school, we worked with some child life, but usually that was among the younger pediatric population.
Yeah, because I believe that they focus on the same age group. Um, I know that you typically would get involved with younger, but I believe that child life specialists would span the definition of what we would say is pediatrics here, which is, I guess, from birth until age 18.
Yeah, and so we're with the kids until they graduate from high school, and we've recently started an alumni group.
So what I'm hearing too is that your approach is not just a medical one. You address the social aspects of caregiving too. And so it's the entire program, not just about having a medical pediatric specialist, for example, right?
If you have somebody who's so focused, then you lose the multidisciplinary, approach. And one of the things is that what's going on at home is beyond the purview of the school, essentially. And so that's why I think the school district really appreciates us coming from the outside in to support the kids, to strengthen the families, and allow them to learn and be successful. Because the schools are so strapped, and now, with COVID and everything, many teachers have quit and the school staffings are low, so that there's an extra strain within the schools. So it takes some of that burden away from them. And there's also the confidentiality issue. But there is great value in doing that home visit, and unless, that's a component, and giving the kids the activities. So in school, out of school, and at home are the three prongs of our approach.
We often end with asking, do you have any advice for others so that young carers can have a better illness experience? What's your advice?
My advice is to learn to keep your eyes open, to say thank you to the kids who may be in this role, and just to love and support them.
That's good advice. The best thing about this podcast series is meeting people like you, Connie, who inspire us through your incredible work and dedication to such an important and unsung group of people, young carers. They deserve the attention that you're giving them.
Thank you for joining us today, Connie.
Thank you for having me.
Thanks for listening. Please visit our website, waitingroomrevolution.com, to listen to our first season about the 7 Keys and to learn more. The podcast is produced and edited by me and Kayla McMillan. Our theme music is Maypole by Ketsa. Please rate, review, and subscribe to our podcast and help us get the word out.